I will spare everyone of my bad Spanish, and so pardon me for poor English too. It's an honor to be here, and some good friends here that I haven't seen in a while. And this is my first time to Mexico City, so thanks for the invitation. Looks good there. Let's start. So, I think endothelial keratoplasty is becoming more common here in Mexico and certainly in Central and South America. We're fortunate in the States to have a lot of endothelial dystrophies, and so we've been able to have a lot of experience with this procedure, and so hopefully I can teach you some things many of you may already know, and hopefully you'll pick up some new things from the talk today. So I'd like to start out with history, being a Manus Fellow, as Enrique can attest, keratoplasty timeline. So this began many years ago, hundreds of years ago, with the Frenchman de Kingsley, who first postulated the artificial cornea. The term keratoplasty came about in 1824. Nussbaum actually performed the first artificial cornea in 1856. Followed by Sellerbeck, who performed the first human corneal tissue transplant in 1878, and then the first partial or lamellar keratoplasty in 1879. And this became more popular with the development of an artificial tree fine, which von Hippel helped out tremendously with. Up until 1905, so really not long ago, did we have the first successful human corneal transplant, Zerm being from what now is Austria. Castillejo brought transplantation to the States in New York and really became popular with the square graft. And the States now have a very well-established eye banking system, but it's really just 1945 was our first eye bank that was established there in New York City. Now we have almost 90 eye banks under the Eye Bank Association of America. Many people don't know this, but the first posterior cornea transplant was done in 1956 in Baltimore, Maryland by Professor Tillett, and it failed due to severe glaucoma from the air bubble. And so it really was abandoned until Mellis described this in the literature in 1999, and that was our first successful posterior lamellar keratoplasty. Boy, since that time it's really taken off across the world, and it really there are a number of publications now throughout the world literature which I think make this the standard of care for corneal diseases where there's just pure endothelial damage. These are the eye bank statistics in the States. Now there are 4 Canadian banks included in this as well, in our statistics. But if you look at the numbers, we're increasing in our number of U.S. transplants. The GEB is the Georgia Eye Bank where I work. And so you see that we only do about 1,500 corneal transplants a year. And then the trends in the U.S. with endothelial keratoplasty, this is where it really has exploded. 0 in 2004 and nearly 22,000 in 2011. The new data will be coming out for 2012 in just probably a few weeks. It's interesting that we hear a lot about DMEC, which is the newer technique of EK, but really only 820 DMECs were done, at least in the U.S., out of these nearly 22,000 grafts. That's about 3%. So it's funny when you come to meetings in the States, you hear a lot about DMEC, but really only 3% of us are doing that right now. So it's slow to pick that up just yet. I think many of you that do endothelial keratoplasty know these advantages well. You avoid that open sky that we hate as a corneal transplant surgeon. That really limits the risk of expulsive hemorrhage. We are able to take out stitches, sutures very quickly with EK procedures, and some techniques now don't even use sutures. And so that really avoids suture-related complications. Stigmatism is much, much less with this technique compared to full-thickness corneal transplant. And the beauty is it gets a faster visual recovery with a significant amount of increased support. So those ruptured grafts that we used to get with full-thickness grafts for endothelial disease are no more in endothelial keratoplasty. I know this is not as common, the number one Fuchs dystrophy. That's the number one reason in the States of why we do endothelial keratoplasty, and it's certainly not as common in other parts of the world, including Mexico. I think pseudophakic bullous keratopathy is probably the world's leading indication if you take all the countries together. But there are other more rare things, Chandler syndrome, posterior polymorphous dystrophy, and we've even done some babies with CHED in Atlanta as well. So just to look at how we do this, first I want to just show you some of the steps, some of the new innovations, and then we'll go over some surgical clips, and then really kind of contrast penetrating keratoplasty, decimase stripping endothelial keratoplasty, and decimase membrane endothelial keratoplasty, and go over some of the world's literature. So there's two ways that you can prepare the tissue. You can do it in the operating room, which I think that's probably the most common way here, where you actually cut the tissue yourself, whether you're using a Moria or some type of an artificial chamber, or you can actually use the femtosecond machine as well. In the States, it's really become more common that we're now having our eye banks do this. If we have an eye bank that works closely with corneal surgeons like we do in Georgia, we can go and teach them how to do this, and then they really become a partner with us to make this procedure more efficient. There's a number of reasons why pre-cut tissue has become so popular in the U.S. The biggest thing is it increases our efficiency because it takes one of the steps of the surgery away. We as a surgeon get charged quite a bit of money in the States if we damage a tissue, and we have to order another tissue from the eye bank, and so that completely eliminates that potential tissue wastage. And then it prevents the need of buying the artificial chamber, and some of those devices can be very expensive, especially if you have to keep maintaining them. Obviously, the disadvantages, you have to have a very well-developed eye bank, and you have to have a very good relationship between the corneal surgeon that's running this program and the technicians that are actually doing the tissue. So that's extremely important because they're becoming a partner with us now in surgery. They're doing the first step of this surgery for us. So it's really important to make sure that they're doing it right. We monitor them very often and actually come in and certify them every 6 months to make sure they're keeping up with maintenance. But this does add more tissue manipulation. We don't see them doing that step for us, and so there are some unknowns with the surgery. This is my eye bank technician, Eric Meineke, that runs the Georgia Eye Bank now, and you can see him with a disposable Moria artificial anterior chamber. And you can see they're quite skilled at doing this. This was probably Eric's 1,000th cut, so he does many of these. And you can see they're very dexterous and really can do just as good a job as me on this procedure. And then the tissue basically gets put in Optisol GS, and they transport it to us via a carrier, which our surgery center is about 10 minutes from the eye bank, which our traffic is not as bad as here, but that could be an hour in Atlanta because traffic's bad there as well. So different insertion techniques, and I think this is really where the world differs in how we actually put in the tissue. And there's really no right or wrong way of how you do it. It's what you're comfortable with and what you get reproducible, efficient results with your patients and what you become familiar with. I first started out doing this with forceps insertion. I then went to some tissue inserters, and I've now gone to a simple technique that I'll show you shortly. This is just probably the first year or so when I first started doing this. And this is, I guess Mark Terry was the first that taught me how to do the forceps insertion. We coat the tissue with Healon. You see the eye bank cut this for me. And I did the 60-40 overfold. I know now he does a 40-60 underfold. These are non-compression forceps. We wash off the Healon. And the incision has to be very large here because you don't want to crush the tissue. And that's one disadvantage of a forceps insertion. The other disadvantage is if there is a shallow anterior chamber or there's a lot of posterior pressure, it's hard to shove those forceps into the anterior chamber. And so that's another disadvantage. The third disadvantage of this technique when we're teaching our fellows and residents is it sometimes tissue can get flipped because very, very thin tissue is hard to unfold and you can lose your orientation. So you see here just injecting the air bubble. I like to do that with a 30 gauge needle at the end of the case to get a good airfill. The boost and glide has become quite popular, and here's showing surgery using the boost and glide. These are the tan forceps to reach across the anterior chamber and just simply allow the tissue to glide through the chamber. This incision can be a little bit smaller than that forceps incision, but again, you still want to avoid the crushing of the tissue. This is the first injector in the States that came out, the NCI injector. You can see a picture of it here. It did have to go through a rather large incision, and for that reason it really hasn't taken popularity in the States. I think probably the most common one here, this is a video that was sent to me by a good friend, David Rootman, in Canada, showing an endoserter. And I like the endoserter, but in the States it's very expensive. It's almost $200 every case. And so if you work in a surgery center like I do that's not in a hospital setting, where we actually have to buy the equipment ourselves, it can be quite expensive for the physicians. And so oftentimes this can be a problem, at least in the States, for private surgery centers. But the nice thing about this is it goes in under irrigation, so you don't have to worry about the chamber collapsing. So they're actually hooked up to the irrigation aspiration handpiece on your cataract device, and you see it just goes right in and it's unfolded instantly. Now here's what I've really gone to lately. I do like that endoserter, but this is more of an economical technique for our patients, and you can see how easy it is. You just slide it through a sheets glide, pull the sheets glide out, and then inject the chamber with air. And that costs about 3 cents. So let's go over some outcomes. Those are some of the techniques that we use. I was fortunate to be involved with this American Academy of Ophthalmology review, which was out in 2009. And then I'll compare this with the really nice report by the Price Group, which looked at 5-year data for Decimate stripping endothelial keratoplasty. So just looking at the visual outcomes, you can see these are very impressive. We like to use Snellen acuity in the States, so 20/30 to 20/60 essentially on our visual acuity as far as the range of vision in those reports. This is much, much better as far as what the visual outcome can be. You know, with penetrating grafts, there's no telling what you'll get refractive-wise. We often get a myopic astigmatic shift. We know with this we're reproducibly getting a hyperopic shift of 0.7 to 1.5 with an average of 1.1. So that's important for the residents and fellows here. When if you're doing a combined case, you always want to do your biometry and aim for a minus. So I typically aim on my calculations for about a -1 for my lens implant calculations, or maybe a -1.25. And there is a difference depending on how thick your tissue is. Thinner tissue, you'll get less of a hyperopic shift, and we're seeing that now with DMAC cases. Induced astigmatism is a huge advantage of endothelial keratoplasty, and in those reports, the average was 0.1 diopters, so that just kills penetrating keratoplasty right there. Endothelial cell loss at 5 years was 53% in the Price study. And if you think about the cornea donor study, which we just heard 10-year data by Mark Manis and Ed Holland at the last Academy meeting in New Orleans, and it showed that the penetrating keratoplasty grafts at 10 years have a 70% endothelial cell loss. So that was really, I think, unexpected for a lot of us. We didn't realize the cell loss would be that high. So really, EK compares favorably to penetrating keratoplasty at 5 years as well. This just shows the hyperopic shift that a number of studies have shown, anywhere, again, from plus 0.7 to plus 1.5. And so you need to think about that. And if you're staging cataract surgery, you might think about leaving them myopic, even if they may not need an endothelial keratoplasty for 2 or 3 years. You try to give yourself a little bit of myopic help. Now, unfortunately, with new procedures come new complications. And so there are some new things we have to think about with endothelial keratoplasty that we did not have to think about with penetrating keratoplasty. We now have an interface, so interface can have problems. You can get blood in the interface. You can tear the iris when you're trying to insert the tissue. You can get the tissue that you insert can actually flip, or the tissue can, even worse, expulse from the eye. And that's not a fun thing. And a lot of these complications can be similar to penetrating keratoplasty, but there are some new ones. Dislocation of the tissue, we don't have that with penetrating grafts. We now have an air bubble introduced into the eye, so that can cause some issues. And then essentially interface complications. Now the other ones can be the same. Here's some pictures of dislocations. There's two types of dislocations. There's a complete dislocation where you walk into the room and you look at the patient and the tissue is completely down in the angle, and that's not a good feeling. And then there's partial dislocations where there's just a cleft of fluid, but the tissue is fairly well centered. These aren't so bad because you can fix these at the slit lamp fairly easily. The ones that are completely detached like these are a little bit harder to fix at the slit lamp, and you might have to take them to a minor procedure room or to your operating room in the hospital. Now in this review, the dislocations were extremely variable, anywhere from 0 to 82%, and that clearly has come down a lot. And I think the accepted range now in most of the meetings is 5 to 12% for dislocations. So if you're in that range, that's good. If you're not, hopefully you can figure out some tips to make that lower. Treatment options, as I mentioned, you can rebubble right in the room at that time, or you can come back later, a week or two. It's not a big issue as long as you don't wait a month or 2 months. In that case, there's more risk of graft failure. Speaking of graft failure, that's another concern with this procedure because we're manipulating the tissue more. And you can see some of these failed grafts. Why did the grafts fail? Well, Dr. Edelhauser in Atlanta with me helped us do some staining of these tissues with alizarin red stain, which the red area that you see are dead, damaged cells, and the white cells are healthy, working cells. And it's just showing you how the tissue crushed from that forceps insertion on that delivery. And then you can see wrinkles in the tissue where you have that red wrinkle that the arrow points to where the tissue's just been damaged from actually folding on itself. So those are some of the reasons why graft failure can happen, but it is quite higher. 5% is a lot higher than penetrating keratoplasty. Now air bubble complications, a new thing. We have air bubble trauma to the endothelium. We have pupillary block from the air bubble, and we also have Eretz-Zavalia syndrome, which is where the pupil gets stunned and frozen and dilated. Again, looking at the air bubble injury, this is a study done with Edelhauser back in the old cataract days where we didn't have viscoelastic and you had to use air. And if you can see, there's an area of circular damage to the outside. Everything in the inside is very healthy. So this is from surface tension. The surface tension goes to the outside, and so the air bubble trauma typically starts on the periphery, which unfortunately is where the endothelial cells are probably more important. Pupillary block, there's two types of this. There's a block where the air bubble goes behind the iris, and a block where it's in front of the iris and you just have the inferior iris kind of plastered up against the inferior cornea. The bottom one's fairly easy to fix. The top one, a little bit more challenging because you have to go back into the eye, get rid of that air bubble. You can try to dilate the patient, have them lay down flat, and sometimes that'll allow the bubble to release. But in my experience, you have to do something, typically somehow doing a laser peripheral iridectomy or actually going in and draining that air from behind the iris. So glaucoma raised 3% in the reviews of both those two papers. So, it's definitely something to think about. We talked about the ways to fix this. This is just showing you the Eretz-Zavalia pupil. This is a man, his right eye, and then the left eye where I did the DSEC. And you can see this was about 3 months after we did it. And it's not completely fixed and dilated, but he doesn't like it because he's got a lot of glare and halos. And that was obviously first described in 1963, and originally described in penetrating keratoplasty and keratoconus. And then we mentioned interface complications, and there can be anything from haze, like you see here, which is sort of a reticular haze. This is felt to be from two things, either an irregular cut from the keratome, which left the collagen fibers against axis, or retained viscoelastic. Those are the two theories as to what makes this happen. So this sort of gives an argument for people that use artificial anterior chambers. Maybe you'll see this less, but I still use viscoelastic. Epithelial ingrowth is another problem that we get, just like we do with LASIK. We talked about interface heme, and then you can just get debris, just like you can with LASIK flaps, which, these are all fairly asymptomatic, and you really don't have to do many things to those patients. As far as the haze goes, it almost always resolves with time, but it takes 6 to 12 months, and it can be very frustrating for the patients. But if you can just get them to hang on, they'll typically end up getting really good vision. The epithelial ingrowth can be a little bit more of a problem. If it's in the visual axis, you may have to go in and scrape that out. A new complication we're seeing, which is a publication that hopefully will be in press coming out in the next 3 to 4 months by Liliana Werner, who is head of the former Apple lab. David Apple, who's now deceased, ran this lab in South Carolina and then moved it to Salt Lake City. So she's in charge of this now. And we're starting to see hydrophilic acrylic IOLs are opacifying in some cases after DSEC. And it's typically eyes where there's been maybe a multiple rebubble, like a dislocation that had to be rebubbled. So that is one of the risk factors of this, but I've just kind of stayed away from hydrophilic acrylic and tried to stay with hydrophobic acrylic, and that tends to solve the problem. So be thinking about that on your Fuchs patients if you think they may need that also with pseudophakic bullous keratopathy. So this is felt to be hydroxyapatite, and which is basically right where the air bubble touches the central IOL. And so unfortunately, because it's so central, these oftentimes almost always need an IOL exchange. And these are not fun cases to exchange because typically the lens has been in for quite some time. Another ominous and horrible complication, which has actually led to me losing an eye from this, with a patient where they get infectious interface keratitis. And this is where you can actually see Candida albicans in the interface. And so I had to actually take this patient to the OR and do a penetrating graft to try to cut this out before it got into the anterior chamber, because it's hard to get antibiotics to this interface. Elmer II up in Chicago in the U.S. has just recently mentioned perhaps doing an intrastromal injection of voriconazole or amphotericin into the interface flap, which is a possibility, but it certainly could detach the graft if you tried that. So this is a challenge when you get this, and it does happen, unfortunately. There's a high mag view of the endothelial button with the Candida species. So I do check donor rims. Do you do donor rim cultures here? Yeah, so I think that really tips you off. If you get, you guys know, if you see bacterial rim positive cultures, it's oftentimes not much of a worry. Sometimes it can be, but if you get a fungal rim culture that's positive, that's much more of a worry, because fungal rim cultures are more have a higher correlation to infection than a positive bacterial culture rim. So obviously voriconazole and amphotericin are very effective against this species. Now let's talk a little bit about DMEC, and obviously for the residents that may be here, DSEC is replacing the endothelium but adding a little bit of stroma to that endothelium and decimase membrane, versus DMEC where we take the stroma out of this. And so obviously the advantages of that are twofold. One is it really is the normal anatomy of the eye. You're not adding extra stroma. And then secondly, there's less risk of that haze because it's an anatomical perfect structure. So you can see here peeling the decimase membrane on the donor, and this is the challenge that I've faced on some of mine, is it's very easy to rip the tissue. Once we peel that tissue, we stain it multiple times with trypan blue, and you can see here it just shrivels right up. And so it's not inconceivable, it's not impossible to have this tissue flip on you. One thing that's important to realize when the tissue's in the eye is the endothelium typically is on the outside of what looks like, you look like they call it a Dead Sea Scroll. It looks like an old scroll from the Egyptian days. And you can see here the blue dashed line is the endothelium, and then the yellow is the actual decimase. And so if you can keep that orientation, it sort of helps you make sure that you don't flip the tissue. Now, Frank Price has now developed a special light that you can apply to the microscope that can help you visualize this a little bit easier. I haven't used that yet, but there's some things out there to help. And then obviously, just like a DSEC, you insert the air. In this case, we typically leave the air in completely without taking it out and create an inferior peripheral aerodectomy, because this has much higher risk of detaching if you actually burp air out at the time of the surgery. So we typically just leave this air bubble in as a complete fill, do an aerodectomy, and I'll typically put patients on acetazolamide just to give them some extra protection. Some of these complications are the same, but the big new one is the donor tissue wastage, which is a problem. Dislocations is the biggest hurdle with DMEC right now. They're extremely high, and if you have a busy clinic the next day and you have done a number of DMECs, it can really mess up your clinic, and so that's a challenge that you have to be careful to face. Even though this is improving, the numbers are still rather high with some of these expert surgeons across the world. Primary graft failure is another problem, and that's one that I've certainly seen a few of, where we just manipulate the tissue more with DMEC, and we're just harder on the endothelium. And as DSEC had a higher risk of graft failure, DMEC has an even higher risk compared to DSEC. Tissue wastage is a big problem. Here I am preparing a tissue, and watch this. Split. Thought it was going perfect, and then it just split on me. So I wasted this tissue, which was not good. So in this Price study, 70% of the donors had donor tears, and 9% were salvaged, but 8% were wasted. And 8% of tissue, the tissue is very valuable. So it's tough when you lose tissue like that. So just looking to end up on long-term success, and this is sort of a schematic of where we are now. Most of the DMEC studies are out to about a year now. There's a few that are coming out longer with the German group by Friedrich Kruse. And then obviously Mellis has some really nice studies as well. But these are the one-year data ranges comparing to penetrating keratoplasty, Decimase stripping endothelial keratoplasty, and then Decimase membrane endothelial keratoplasty. And it does look like the endothelial cell loss, is fairly good with DMEC, but I'll caution you that these guys are, they really have a lot of experience with it, and they're still seeing those amounts of cell loss. And so that, it's a little bit concerning. The 5-year data, we have the Cornea donor study that shows 70% endothelial cell loss. The Price study really shows a good, fairly consistent number at 50%, which other studies are trying to come to agree with those findings. And so we don't know DMEC data yet at 5 years, so it will be interesting to see. We'll say one advantage that we're seeing with DMEC, though, is there's a less risk of endothelial rejection. And that does make sense because you're just basically replacing that small layer of the donor cornea. And so that certainly does appear to be showing less risk of rejection compared to penetrating and in a DSEC procedure. So if you think of the pros and the cons, I get asked this, when should I switch to DMEC? And there's really no right or wrong answer, but these are the things I would think about. DMEC does restore the normal anatomy. There's no stroma to stroma layer, so it really reduces the risk of that stroma haze or interface haze that you sometimes can see with DSEC. There is a reduced risk of endothelial rejection that it does appear to be actually true in the data, but it does have a higher primary graft failure rate, so you have to keep that in mind. The cons, obviously the donor preparation is still a challenge, and I think this is where it really needs to be perfected to make tissue not be wasted, just like we do with DSEC. DSEC has now become very safe for tissue. We need to get DMEC that same way. There's consequences of damaged tissue. We lose tissue in our donor pool. As a surgeon, you might get charged extra fees. You might not be able to do the case. You might have to cancel the case, which can be very sad for the patient. Increased risk of tissue dislocation is probably the biggest complication of DMEC right now, and how to face that in a busy clinic is a challenge. And then certainly we don't know about endothelial cell loss, so I think time will tell. Intuitively, I think we manipulate the tissue more with DMEC, So my concern is that endothelial cell loss might be higher, but we'll just have to wait and see. So we'll just kind of conclude here, and then the last decade has seen amazing changes for corneal surgery. It's been very exciting, here in Mexico and the States, all across the world. A procedure that's really fairly new when you think about it, just 1905 with the first successful transplant. But in the last 10 years, we've seen just an explosion of procedures in the cornea world, which is exciting. I think we can say pretty easily that endothelial keratoplasty has replaced penetrating keratoplasty for the surgical treatment of corneas that have diseased endothelium by itself. Now, certainly if there's multiple diseases like keratoconus and F.A.C.S or a scar and pseudophakic bullous keratopathy, those candidates are probably better candidates for penetrating graft. But for pure endothelial disease, I think EK is the way to go now. Our techniques continue to evolve with EK, and they still continue to evolve every few months. But we do need to realize there's a new set of complications, and so we have to be aware of that and be aware of how to handle those complications. Some of it can be quite devastating, as the infectious ones are. And I think DMEK is gaining popularity, but it's still not there yet. I'm hopeful that with all the different minds that are now starting to do this and starting to think about it, that we'll eventually one day have it as easily and as efficiently as DSEK has become. Thank you.